Know your parasite. Leishmania, the dark side of protozoa. For your convenience, each relevant section opens with the symbol of the topic it deals with. What is it? A flagellated protozoan. Modes of transmission. Sandfly bite. Epidemiology. Worldwide. Common in Israel. Clinical presentation. Cutaneous, mucocutaneous, and visceral disease. Diagnosis. Lesion sampling for microscopy and PCR. Treatment. Topical and systemic therapies. Prevention. Vector control. Reservoir animal management. The promastogote is the elongated, flagellated form found in the sandfly. The amastogote is small, round, and intracellular, the form found inside human macrophages. Here we see amastogotes under the microscope. These are small, round intracellular parasites, typically clustered inside macrophages. Each amastogote contains a nucleus and a kinetoplast, a key diagnostic feature. This is the replicative form of leishmania in humans, hidden, protected, and difficult to eliminate. Here we see promastogotes. These are elongated, flagellated forms of leishmania found in the sandfly and in culture. The long flagellum provides motility and helps the parasite attach within the insect gut. This is the infective stage transmitted to humans during the sandfly bite. Life cycle. A parasite in its promastogote form, with an anterior flagellum, is injected from the salivary glands of the vector, a female sandfly, during a blood meal. The vector's saliva causes aggregation, a gathering of the gang, like hoodlums in a neighborhood, of macrophages, a chemotactic effect, thereby indirectly promoting rapid and successful infection. The parasite penetrates phagocytic cells in the skin and subcutaneous tissue, loses its flagellum, and becomes an intracellular amastogote. Both amastogotes and promastogotes have two important DNA-containing structures essential for their identification, the cell nucleus and the kinetoplast, which is mitochondrial DNA encoding for energy production for flagellar movement. Disease in leishmaniasis is caused by the amastogote form. After entering the host, amastogotes multiply inside macrophages and trigger a local inflammatory response. In cutaneous disease, this leads to localized skin lesions. In mucocutaneous leishmaniasis, infected cells spread to mucosal tissues, causing progressive tissue destruction. In visceral leishmaniasis, amastogotes disseminate through the bloodstream and accumulate in organs rich in macrophages, such as the spleen, liver, and bone marrow. During a blood meal, sandflies ingest circulating or tissue-associated infected cells, allowing amastogotes to enter the insect and continue the life cycle. The vector is the female sandfly. It belongs to the genera Phlebotomus and Lutzamia in the Americas. Sandflies are very small. They're about 2 millimeters in size. They can pass through ordinary mosquito nets. They are weak flyers. They fly close to the ground. They are active mainly when there is no wind. Sandflies need high humidity to survive. The immune response to leishmania is a delicate balance between protection and pathology. Upon infection, macrophages engulf the parasite, but successful parasites survive and replicate inside them. The body responds with T helper cells. Th1 responses activate macrophages to kill the parasites, producing interferon gamma, while Th2 responses can worsen infection by promoting antibody production without effective parasite clearance. Understanding this balance is crucial for vaccine development and immunotherapy strategies. The killing path Th1 activation, cell-mediated killing. Activation of Th1 combined with increased secretion of inflammatory mediators IL-12 and interferon gamma will lead to the activation of macrophage killing mechanisms by lysosomal killing agents, which include NO, nitric oxide, free radicals, lysosomal enzymes. Leishmaniasis affects millions of people worldwide, primarily in tropical and subtropical regions. The disease is transmitted by the bite of infected female sandflies. Different species of Leishmania cause distinct forms of the disease, ranging from cutaneous lesions to visceral infection. Understanding where the disease is endemic, who is at risk, and how transmission occurs is key to prevention and control strategies. Leishmania parasites maintain their life cycle in animal reservoirs, which play a crucial role in sustaining transmission. Dogs are the primary reservoir for visceral leishmaniasis, while rodents often harbor cutaneous species. Identifying and managing these reservoirs is essential for controlling outbreaks and reducing human infection risk. Visceral leishmaniasis, also known as caloazar, is distributed across parts of Asia, Africa, Latin America, and the Mediterranean. The disease primarily affects vulnerable populations, including those with weakened immune systems. Co-infection with HIV significantly increases the risk of severe disease and complicates treatment. Mapping the geographic distribution helps guide public health interventions and control measures. This invasion of the cycle happens because humans, non-immune populations, move into endemic areas. Construction creates moist microhabitats, e.g., from waste irrigation, that boosts sandfly numbers. Proximity brings biting sandflies closer to homes, infecting people who enter the zoonotic loop unintentionally. Leishmaniasis is a prime example of how microbial diversity dictates disease pathology. While all forms are transmitted by the sandfly, the infecting species determines the clinical fate. Species like L. major and L. tropica stay localized, causing cutaneous leishmaniasis, characterized by skin ulcers. In contrast, L. brasiliensis can migrate, leading to the destructive tissue loss of mucocutaneous forms. Most severely, L. donovani and L. infantum exhibit visceral tropism, invading internal organs like the liver and spleen. Ultimately, the clinical face of the disease is a direct result of the specific parasite strain involved. This is a classic L. major lesion. Notice the wet ulceration. It features a depressed center, raised borders, and a moist, crusty surface. These sores are typically painless, but can lead to significant scarring as they heal. In L. major specifically, the progression is fast, often reaching this ulcerative stage within just a few weeks. In this slide, we see additional cutaneous lesions caused by Leishmania major. In this slide, we see another Leishmania major lesion, this time located on the nose. This slide illustrates the different presentations of cutaneous leishmaniasis. On the left, we see Leishmania major, which causes zoonotic cutaneous leishmaniasis. These are typically wet lesions characterized by a more severe inflammatory reaction. In contrast, as shown on the right, Leishmania tropica causes anthraponotic cutaneous leishmaniasis. These appear as dry lesions with much more minimal ulceration compared to the major strain. Looking at these images, can you guess which ones are Leishmania and which are something else entirely? While the first two cases on the left are indeed leishmaniasis, the image on the right is actually gas, group of strep. This highlights the vital importance of acknowledging the limitations of a physical examination alone. Appearances can be deceiving, and accurate diagnosis often requires more than just a visual assessment. Can you guess now? And now? And now? The guessing game. Go for it. This slide demonstrates how the host's immune response dictates the clinical outcome. On the left, Leishmaniasis recidiva, often caused by L. tropica, represents a severe immunological reaction despite very few parasites being present. In contrast, on the right, diffuse cutaneous leishmaniasis associated with L. ethiopica occurs when low immunity allows for numerous parasites and widespread lesions across the body. Moving to the Americas, New World leishmaniasis presents a broader spectrum of disease. While species like L. mexicana cause standard cutaneous lesions, L. brasiliensis is particularly concerning. It can progress to mucocutaneous leishmaniasis, leading to severe pharyngeal involvement and the destruction of nasal and oral tissues. As seen here, the clinical impact ranges from simple skin ulcers to disfiguring mucosal damage. Finally, we see the real-world impact on travelers returning to Israel from South America. These cases often involve the Leishmania brasiliensis complex, which can be deceptive. A patient might have a simple scar from a healed leg ulcer, only to develop a new, indurated patch on the nose a year later. As shown in the illuminated image, this can progress to a perforated nasal septum or severe oronasal destruction. It serves as a critical reminder that with New World strains, a healed skin lesion isn't always the end of the story. Finally, we address the most severe form, visceral leishmaniasis. This case involves a 1.5-year-old presenting with a prolonged fever and significant abdominal distension caused by an enlarged liver and spleen. Lab results show pancytopenia, and as seen in the biopsy, the bone marrow is literally teeming with parasites. Without a high index of suspicion and prompt treatment, this systemic infection is almost always fatal. Visceral leishmaniasis, or kala-azar, follows a chronic, progressive course lasting weeks to months. Patients suffer from persistent fever, night sweats, and severe wasting or wasting syndrome. The hallmark of the disease is massive hepatosplenomegaly, as seen in these clinical photos. Lab results typically reveal severe anemia, pancytopenia, and hypergammaglobulinemia. Without treatment, the combination of organ failure and secondary infections makes this form of the disease fatal. Accurate diagnosis is critical and relies on direct parasite detection. The primary methods shown here include scraping the ulcer bed or performing a punch biopsy from the active edge of the lesion. These samples are used for tissue impression smears stained with Giemsa to visualize the parasites and are further divided for histology, PCR, and culture to confirm the specific strain. To confirm the diagnosis, we use microscopy to identify mastigote forms, which can be seen both intra- and extracellularly in these stained tissue samples. For definitive species identification, the sample is placed in a complex culture medium for up to 4 weeks. This allows for the growth of promastigote forms, which are then analyzed via isoenzyme analysis or PCR to determine the exact Leishmania species involved. Finally, PCR has become a gold standard for rapid and highly sensitive diagnosis. This slide shows the procedure for a cutaneous lesion. After cleaning the area, a sterile swab or small tissue sample is taken directly from the ulcer. Unlike traditional cultures that can take weeks, PCR provides a definitive species identification within hours, allowing us to distinguish between strains and guide the most effective treatment plan immediately. For diagnosing the visceral form, we must sample internal tissues where the parasites reside. The gold standard involves bone marrow aspiration, or more rarely, splenic or lymph node aspirates. These samples are then analyzed using microscopy to identify bone marrow mastigotes or placed into a specialized NN, Novimac-Nielnicol, culture medium to encourage parasite growth. Additionally, serology can play a supporting role in confirming the systemic infection. Treatment strategies for leishmaniasis depend entirely on the clinical form. For simple cutaneous leishmaniasis, we often have the option of local therapy or even a wait-and-see approach for certain self-healing strains. However, for mucocutaneous and visceral forms, aggressive systemic treatment is mandatory to prevent disfigurement or death. Standard systemic agents include pentastam, pentamidine, and amphotericin B, often administered in its liposomal form known as ambisome. When discussing treatment outcomes, we must manage expectations regarding scar formation. As seen in these clinical images, even with successful intervention, permanent scarring is the typical endpoint of the healing process. Furthermore, research has shown that early treatment of cutaneous leishmaniasis doesn't always prevent an ulcer from developing initially. Our primary therapeutic goals are to accelerate healing, reduce the total number of lesions, and most importantly, prevent the progression to more severe mucosal or visceral forms of the disease. This table summarizes our current therapeutic arsenal, categorized by local, oral, and intravenous administration. While local options like thermotherapy or cryotherapy are cost-effective, they carry risks of burns or depigmentation. Topical paromomycin remains effective specifically for L. major. For more complex cases, oral options like miltefosine show high efficacy, but require close monitoring. Finally, for severe visceral or mucosal disease, intravenous pentastam or liposomal amphotericin B are our most potent tools, though they are high cost and necessitate rigorous kidney and blood count monitoring due to potential toxicity. Cool down the villain. Freezing, like cooling but extreme. Burn the abomination. Smear it with paromomycin. Results with paromomycin. Results with paromomycin. Results with paromomycin. Smear it with liposomal amphotericin B. A critical point to communicate to patients is that while treatment can clear the infection, it does not prevent the natural progression of the lesion towards scarring. As shown here, even with early intervention, the inflammatory process often leads to the development of an ulcer followed by a permanent, characteristic scar. Our goal is to shorten this duration and prevent complications, but we cannot entirely bypass the scarring phase. Give miltefosine orally. When local treatments are insufficient, miltefosine offers a potent oral alternative. It works by inhibiting mitochondrial cytochrome C oxidase, which decreases oxygen consumption and ATP levels in the parasite, ultimately triggering an apoptosis-like death in L. Donovani promastigotes. While it shows very high efficacy, it is an expensive medication restricted to patients over 12 years of age and requires careful monitoring. This highlights the ongoing challenge in leishmaniasis care, balancing high treatment efficacy with cost and patient safety protocols. Inject pentastam directly into the lesion. For localized cutaneous lesions, paralesional infiltration with pentavalent antimonials is a common therapeutic choice. The procedure involves injecting the medication directly into the edges of the lesion until complete blanching is achieved, typically performed 1 to 3 times a week for up to 8 weeks. However, this method presents significant clinical challenges. The injections are notoriously painful and often require local anesthesia. In the pediatric population, this becomes a major limitation, as the distress and pain associated with repeated needles frequently necessitate procedural sedation or a shift towards systemic alternatives. Give penistam intravenously. Finally, we look at the results of intravenous pentastam, sodium stibogluconate, for severe cutaneous lesions. In cases of complicated or systemic disease, particularly in pediatric patients, 4-ambisum is a highly effective treatment of choice. These clinical images show children with multiple or severe facial lesions before and after treatment. As documented in the study by Ben Schimmel et al., we see a dramatic clinical improvement within 6 months to a year following the completion of the protocol. While the lesions have cleared successfully, the long-term follow-up images illustrate the typical cosmetic outcome, where the active infection is replaced by stable, healthy tissue, though some degree of residual scarring may still be present. This slide illustrates a challenging case of a severe facial lesion that required a sequential treatment approach. Initially, the patient was treated with IV ambisum, liposomal amphotericin B. Due to the persistence or complexity of the lesion, therapy was subsequently transitioned to miltefosine, Impivido, an oral agent that induces apoptosis in the parasite. As you can see in the follow-up images, this combined regimen led to a significant clinical resolution, although it underscores the need for personalized protocols in resistant or difficult-to-treat cases. This slide highlights the frustration of using oral alternatives like fluconazole or azithromycin, which lack the proven efficacy of miltefosine. Given the inconsistent evidence, these treatments often feel like a lottery. Despite being low cost, they risk therapeutic failure, liver damage, or a rebound effect, making them a secondary choice only. This slide presents the big dream, using nitric oxide spray to kill a mastigotes naturally, mimicking the body's own immune response. In theory, this topical approach would offer high efficacy with minimal side effects. However, it remains a dream due to the immense technical and financial hurdles required to develop a stable, portable delivery system. For now, we are left with complex systemic drugs rather than a simple deodorant-style spray to eliminate the parasite. To wrap up, we look at the Israeli government's historical responses to outbreaks in the Negev, L, Major, and Samaria, L, Tropica, which were often as unconventional as they were ineffective. The state issued orders to hunt rock hyraxes, a key reservoir for L, Tropica, and even paid millions to dismantle the rocky terrain where they hide. As the slide suggests, the hyraxes simply moved to the next rock, while contractors sold the cleared stone as gravel. It's a stark reminder that without a stable, scientific solution like a nitric oxide spray or more accessible therapies, our prevention efforts can sometimes feel as circular as the hyrax's movements. Beyond ineffective environmental measures, the systemic response to leishmaniasis has also faltered in the research arena. Despite multiple grant applications, the government has largely failed to fund medical research for a vaccine or specialized drugs for cutaneous forms of the disease. Instead, hundreds of thousands of shekels were devoted to checking parasite carriage in sandflies across remote Moshavim, a result that, while academically curious, did little to advance clinical care or provide tangible relief to patients. This reflects a long-standing pattern of prioritizing laughable outcomes over serious medical breakthroughs. Our final look at prevention highlights the shift from active environmental intervention to more symbolic and often less effective measures. The government placed warning signs at the entrance to IDF bases in endemic areas, yet failed to offer soldiers practical treatments or solutions. Significant efforts were also made to eradicate sandflies, though these resulted in very limited success. On a more positive note, there has been support for clinical laboratories to promote molecular diagnosis through PCR. However, while our diagnostic precision has improved, the overall prevention strategy remains a patchwork of laughable outcomes and missed opportunities for real medical breakthroughs. This slide illustrates the struggle of disease control. Sandflies and reservoirs are nearly impossible to eliminate through current environmental means. Prevention efforts, like the warning signs shown here, are often symbolic and provide no real protection for those in the field. Without a vaccine or research funding for new drugs, we remain stuck between ineffective environmental measures and difficult clinical treatments. Our final slide focuses on the search for a vaccine, which remains the holy grail of leishmaniasis control. While numerous strategies, including killed, attenuated, and DNA vaccines, have been trialed, none are currently in clinical use. Historically, Israel even administered a live vaccine to soldiers in the 1960s. However, the severe side effects and significant lesions caused by the live virulent parasites far outweighed the benefits. Today, despite ongoing research, we are left without a safe and effective immunization tool, leaving patients reliant on the complex treatments discussed earlier. In summary, Benjamin Franklin's principle, "an ounce of prevention is worth a pound of cure," remains our biggest challenge. Today, the pound of cure is costly, involving painful injections and permanent scarring. Without a vaccine or effective prevention, we continue to pay a high price in patient suffering. Real progress requires shifting our focus from managing lesions to investing in medical breakthroughs. Thank you. Finally, for a deeper dive into the bizarre world of medical parasitology, I invite you to check out my book, Living Alongside Parasites, A Host's Diary, available on Amazon. It is an exhaustive, scientific, and humorous resource designed for students and doctors alike. You can find the link in the comments. I am sure you will find it a fascinating read. Thank you for your time.